All right, everyone, welcome back. We are settling in for our next speaker. We are grateful to have partnered with Children's Minnesota to offer 4 AMA PRA Category 1 credits for physicians and 4 ANCC nursing contact hours. Please take a moment to review additional accreditation information from Children's Minnesota. Next, we have our standard disclaimers and confidentiality protection statement to share from Children's Minnesota. Please ask us if you have any questions about these disclaimers and/or confidentiality protections. Lastly, we have our standard faculty disclosure announcement. Our planning committee and presenters have no relevant financial relationships to disclose. Please ask us if you have any questions about these disclaimers, disclosures, and/or accreditation information. For our next presentation, we are joined by Kirk Hughes. Kirk is a nurse working as a certified specialist in poison information and the education director for the Minnesota Poison Control System since 2000 and has managed over 98,000 toxicology-related cases. He retired from the fire service after 27 years in July 2022. He has also worked as an investigator for the Hennepin County Medical Examiner's Office and provided expert witness services for the Hennepin County Prosecutor's Office. His publications have appeared in the Journal of Clinical Toxicology and American Journal of Perinatology. Kirk has been an avid Minnesota EMSC Advisory Committee member for many years and has presented numerous times at various pediatric trainings. Kirk's presentation, Pediatric Poisoning, will cover the objectives seen on the screen. Thank you so much, Kirk, and you can take it away.
Sounds good. Thank you very much. All right. Well, thank you to the organizers for having me. It's always a pleasure to be able to present on behalf of the Minnesota Poison Control System, and in this case, on behalf of the poison centers in the United States. So with that, we'll get going. Hopefully. There we go. So I just like to throw a little slide in there. Usually it's got weird things like cryptids and alien abduction day, but I thought this world today, especially listening to the first two speakers and my experience in this, is we need a little more kindness. So let's make every day World Kindness Day, not just November 13th. So a little introduction to the poison centers. We used to be the American Association of Poison Control Centers, the AAPCC. We went through a naming rebranding at the higher level, at the national level. We are now just called America's Poison Centers to make it more simplified. They are our accrediting body. We have to reaccreditate every 7 years now. And then we have to have things like a board certified medical director that's a board certified toxicologist, open 24/7, all those sorts of things. Now, there are 55 poison centers in the United States. Not every state has a poison center proper, but every state is represented regionally. And the Institute of Medicine report in 2004 identified regional poison centers as being the real strength and the best structure for America's poison centers. And a lot of the reason for that is we have knowledge within our states that we represent of what the capabilities are. For example, in Minnesota, we have 3 pediatric hospitals within Minneapolis, St. Paul. 2 can do hemodialysis and pediatrics, 1 can do CRRT. And so knowing the difference of that can really be beneficial when we're talking to EMS and where they should bring the patients and those sorts of things. So we also know our flora and fauna best. So mushrooms, for example, the creatures that bite, sting, and venomate. Unfortunately, we don't have any in Minnesota, or fortunately for some of you. It's an area of interest to me, but we do have plenty of mushrooms, which is another area of interest to me. There are 55 accredited poison centers. As I previously stated, there's not one per state, but we, for example, in Minnesota also cover North Dakota and South Dakota, and we provide the accredited poison center for them. California has 3, North, Central, and South. And then Texas, of course, has 5 because everything's big in Texas, right? The staffing for most of these poison centers for the CSPIs, which is a certified specialist in poison information, are primarily pharmacists or nurses who are specially trained. You can have other people that do that too. But we also at the Minnesota Poison Control System have what we call poison information providers, and we utilize pharmacy students to take those calls. They kind of take our quote unquote BS calls. My kid ate butt paste. My kid ate the contents of a glow stick. Things will not result in serious morbidity, mortality. As I stated before, we have to be open 24/7. We are HIPAA compliant. Totally understand that if you've never been contacted by a poison center on the floor and we're following up on a patient, because we do that until they are cleared toxicologically, we will follow up. It's okay to talk to us. We are identified as part of the healthcare team once we are consulted. Our particular poison center in Minnesota is located in Hennepin Healthcare. So we're at a level 1 trauma center in Minneapolis, 1 of 2. And then we have another level 1 trauma center across the river in St. Paul, which we share a toxicological fellowship with. So we have a tox fellowship at our poison center. And it costs you nothing as the user to utilize our services in our state. Every poison center has kind of a different modality in which they go ahead and collect their funds and fund themselves. So in our state, we don't have the need to go ahead and do that. So just some kind of fun facts in there. Again, this is kind of semi-representative of most poison centers. We took 53,000 calls. These are Minnesota numbers only, just as an example. I think the big thing to highlight here is that 27% of the cases that we managed were from healthcare providers seeking treatment of the poison patient. We are an integral part, and I had no knowledge of this. I mean, I did fire EMS for 27 years. And I did that 2 years prior to me getting on board with the Minnesota Poison Control System as an information provider starting out and eventually as a certified specialist in poison information. I had no clue that I could call the poison center and say, hey, I get a kid who drank bleach. What do I do? I mean, to us at the fire service at the BLS level, we're like, oh my gosh, this is going to kill the kid. This is going to cause serious illness and death. And much to our chagrin, and we probably had a lot more anxiety than I needed to, when all I had to do is pick up the phone, call my poison center that represents my state, and say, hey, I got this 4-year-old, what do I do? And they can walk us through that. So we like to say they come alongside and help out, and it's one of my real passions, having been doing fire EMS for so long, is to let them know that we're out there. So my goal is to go ahead and get at least 10% a year and try and increase that by a couple percent every year. We're at about almost 10% on track this year. The other thing that was stated previously is that ERs are busy places. And if we can go ahead and reduce the load safely in the emergency departments, so we can free up those clinicians and those professionals to go ahead and do what they need to do in an effective and timely fashion. If you call the poison center, 92% of the time that you call from a home setting, we can safely keep you at home. And those numbers are comparable with all the other poison centers. So there's this guy who lived a long time ago, Paracelsus, and he is known as the father of toxicology. Basically, he said it's the dose that makes the poison. So even water, if drank in a large quantity in a short period of time, has a potential to have a serious outcome. Though it would take a lot of water in a short period of time to do that. Other things, so that has a wide therapeutic margin. Things like bupropion, otherwise known as Wellbutrin, have what we call a narrow therapeutic margin. We know that people who take upper therapeutic doses of 600 milligrams a day have a less than 1% chance of having a seizure just from that upper therapeutic dose. So it's really the dose that does make the poison. Everything has a potential to be poisonous or toxic. Routes of ingestion, obviously by far and away, right around 80% or so, ingestion is the most common route of poisoning. GI decontamination. Now, I'll probably be giving away my age a little bit here, but when little Kirk was 2 years old, 56 years ago, my mom was a nurse at Minneapolis Children's. Single mom, worked 2 jobs, had 2 boys that were pretty rambunctious, and she went ahead and did the best she could, but she couldn't watch us all the time. So what happened back in those days is I got into actually children's chewable aspirin. And yes, for those youngins out there, we didn't have Tylenol forever. We did take aspirin. We all didn't die of Reye's syndrome, though that's a potential, and we have safer things now. But I ate the children's chewable aspirin, the orange chewable bear. It was up high on a shelf. I was about 2 years old, and mom was in doing whatever she's doing. And I look up and I go, oh, the candy, because she put it up high, but not out of sight. And so I knew what that was. And I go, oh, that tastes good. So that day I became a mountain climber, and I decided to eat all the children's chewable aspirin. And I wound up in the Minneapolis Children's ER many years ago. And I got my stomach pumped, otherwise known as gastric lavage. Now, that was also a time when you could puke people at home using syrup of Ipecac. Ipecac is actually a plant derivative. It causes convulsions of the stomach. And I can tell you, if you've ever seen the Family Guy, they drank the Ipecac and the last one to vomit got the piece of pie from, whatever bakery it was or store it was. I've actually done that, and I tried the Ipecac, and I did vomit forcibly 3 times, and my chest hurt for 3 days after. Obviously, it's not the best way to decontaminate people. And so back in December of 2002, the American Association of Poison Control Centers put out a position paper stating that syrup of Ipecac should no longer be used for gastric decontamination, followed closely by the American Academy of Pediatrics in January of 2003. So we don't use that anymore. Now we have activated charcoal. Activated charcoal is basically pyrolyzed coconut shells. They've been superheated to make them more absorbent. You drink it, and it's supposed to go ahead and bind the toxins in your stomach to prevent them being bioavailable to other tissues and other systems within your body. And then you poop out a nice, wonderful black slurry. We don't do a lot of that as much as we used to, though it's kind of like everything, like in EMS, everything is cyclic. I'm noticing some of the younger toxicologists are offering more activated charcoal. As a general rule, if it's less than an hour, they are able to drink it themselves, and it's potentially life-threatening. Those are some of the parameters that a lot of CSPIs use and a lot of toxicologists use. There is a great variance depending where you've been trained, where you did your tox fellowship, who your toxicologists are and where they were trained. So a lot of that. And then we have our pumping the stomach, otherwise known as gastric lavage. This is a lost art. There are not many people that know how to do this, except the old nurses in the ERs that have been around for decades. And they're like, oh, I remember how to do that. But generally, it's a very invasive maneuver, and it's something that we would rather not do unless we absolutely have to, where serious morbidity or mortality was almost for sure going to be on the horizon. So, kids, which is why we're here today. I love this. This is called the Pediatric Assessment Triangle. If you're outside of EMS or in pediatrics, you probably don't recognize this, but this is one of the things when you walk into a room, when you have a sick child, whether it's in the clinical setting or whether it's in an EMS role, you walk into a house, you want to know right away how that kid's doing, because obviously the number one way, as we all know, that kids expire, unfortunately, is because of respiratory insufficiency, whether that's trauma, whether that's disease pathologies, or whether that's due to poisoning. So I always like to teach this. The other thing that I think a lot of people don't understand is, and I didn't understand this, I figured that there were thousands to tens of thousands of kids dying of direct of toxicological mechanisms directly, in the United States. And that's just not the case, thankfully. We have a lot of work to do. I mean, even one child is too much. But the biggest thing that it was pointed out to me early in my career was the kids are pleasure seekers. If it doesn't taste good, they're generally not going to eat much of it. And there are very few things where 1 or 2 pills, 1 or 2 sips of anything, or 1 or 2 inhalations of anything are going to cause any serious morbidity and mortality. They're out there. We know what they are. But thankfully, most things are pretty well tolerated. Now, obviously, the exceptions would be children that have trisomy 21, which is otherwise known as Down syndrome, autism, which is a very broad spectrum, some very functional children. But sometimes the crunch of something, though it doesn't taste good to children without that condition, that the person, the crunch might bring to that autistic child pleasure to their brain, and they may continue to eat more than other children might. So these are not the children with these disabilities are not the ones we keep at home 92% of the time. Obviously, we're going to advocate for them. The other thing, us being educators, in addition to being clinicians, we need to go ahead and let people know about, areas that we know that it can be potentially dangerous to children. The holidays are coming up. A lot of us celebrate various forms of Thanksgiving, various forms of New Year's, various forms of the Christmas holidays and those sorts of things. we have a lot of grandparents who haven't been around young children for a long time come. And this is when we see our most serious morbidity, mortality, and prescription medications is when you visit grandpa and grandpa or they visit you. And the holidays is one of those big times. So please, please, please keep your medications up high and out of sight, or preferably down low and locked up when you're traveling. Educating the kids is great, but eventually, if they're pretty purple pills at 4 years old, if they have access to them, after you've told them that they're bad, they're going to go back and try and maybe look for them, go, ooh, pretty purple, and give it a taste. And hopefully it's not that 360 milligram diltiazem, which can ruin everybody's holiday. So there, every day should be a happy lock up your meds day, or happy lock up your poisons or toxins day. So these are some of the new things that we're actually seeing. These are the wonderful water beads. Now you're saying, well, these aren't toxic. They actually say non-toxic on a lot of them, and that's absolutely true. But as you'll find out, the poison centers get dumped on with a lot of things that they can't pigeonhole to certain things like trauma. We get lumped in with trauma a lot, even though that poisoning, I guess, can be traumatic, but they don't know where else to kind of pigeonhole. So we're kind of unique. So we get things like rabies, which is actually infectious disease pathology. We answer a lot of questions about that. And we answer a lot of questions about foreign bodies that can go ahead and expand and cause bowel blockages or GI problems. And that's what these water beads are. The ones that are actually down in the lower right-hand picture that are inside the stress balls, we've actually done some informal studies within the poison center and put those in water. They don't expand very much. So these are just foreign bodies. These are choking hazards if the shells of these balls break and the little tiny balls come out. There's other ones, though, like the Orbeez and those sorts of things, that expand up to 10 times or more when they're put into water. And obviously, when a child swallows them, because they look like candy, they're kind of chewy. They're not meant to be ingested, but young children, they explore by putting things in their mouths. And our GI tract is full of water. And as it makes its way through our GI tract, it can go ahead and expand and cause bowel blockages, mechanical blockages, and the like. And so that's the problem with these. So I would be very cautious about bringing these into your home. And if you do, just make sure that you keep them up in the appropriate places so that your children don't get into them or they're being supervised appropriately. And if they do get into them, give us a call. So we are now, you can see some, I put up our current Minnesota Poison Control System as MPCS, recommendations for water beads. There have been some papers out there, and I've referenced some of them down here, that up to 30 days out, some children have had bowel blockages, and the number one thing that they saw was vomiting. So obviously, we can't prospectively do these types of tests in children to see who's going to get poisoned and who's not in what instances. So what we're doing is we're collecting a lot of data, and we're being out of an abundance of caution, following up at 24 and 72 hours, and then instructing them that their child vomits after ingestion, these up to 30 days, that they should be evaluated at a healthcare facility. These are magnets. These are particularly dangerous. And as you can see here, the American Association of Pediatricians warns parents about major safety risks of magnets found in reusable water balloons. So as was referenced earlier, I worked for the Hennepin coroner's office as a death scene investigator for 2.5 years as an ancillary job. We had a child that was brought in not to actually to our coroner's office, but to a different one. But they were brought in, 3-year-old died unexpectedly, didn't know why. They opened her up, and during the autopsy found 13 magnets in different parts of her small intestine that were actually adhered together through the tissue, causing bowel ischemia, obviously resulting in death. So there again, not really a toxic issue. We're not worried about the metal in here. This is just more of a foreign body that can cause other things just because of the way that they operate. Another big one, button batteries. Our recommendation that is anytime a child has ingested a button battery, to go ahead and get to a place where they can be x-rayed within 2 hours whenever possible, because there have been perforations of the esophagus. They have a particular tendency, and retrospectively look at tens of thousands of cases, to get stuck in the back of the throat and to have minimal symptomology. I would have called BS on this if I had been sitting in a session as a fire EMT, listening to this going, well, there's no way the kid would have choked. We're finding that a lot of times that they're asymptomatic in a significant, statistically significant amount of time, and they have minimal symptoms, and that stuck in the throat within 2 hours, it can go ahead and cause a hole in their throat. As you can see here in the hot dog, this is one that I've actually I kind of do this. I'll cut a little slit in it. I'll put a 2032 battery in it. And within the end of the time that I'm talking, within usually about an hour, this is what it looks like, which could represent the tissue in their esophagus. Another time, another bad thing is we like our falls in Minnesota. We like our pumpkin lattes and all that kind of stuff, as you all probably do. We also like to have pretty fires. And so we've actually had some cases where children have opened up the flame colorant that's meant to be thrown in its entirety into the flames. It burns through the packaging, and then it starts producing pretty flames. The copper sulfate that produces the blue-green flames is actually quite caustic to our GI tracts. It's in a high percentage. And so we have actually had people that have had burnt esophaguses secondary to ingesting this, thinking it was candy. And then there's the things that are common calls. This is one of our most common calls. It could be Desitin, A&D ointment, or anti-monkey butt. So the active ingredient in here is zinc oxide. Zinc oxide is not toxic to anybody, but the packaging states if swallowed, get medical help or call poison control immediately. That's probably because of an overzealous legal department within those organizations. But we know that all that's going to happen if you eat too much anti-monkey butt is you're going to get diarrhea, and you're going to need more anti-monkey butt to help with the irritation that results from that. Silica gel packets. This one says do not eat, throw away. This is another very common call we get because it says do not eat it. It says that because the packet as a whole is a choking hazard. The individual balls inside there, usually clear, are silica dioxide, which is a fancy word for sand, basically. And so sand isn't toxic. It just might give you some gritty poo, and that's about it. So this is one of our kind of bread and butter calls that we allow our information providers to take. I think this was covered sufficiently by our previous speaker. What I can tell you is I've been a witness to a lot of trauma in my life. Not personally as far as being done to me, but in the course of being in combat and war in the first Gulf War, having been seeing many children and many horrific things in my 27 years doing fire EMS, seeing atrocities and picking up dead bodies and doing investigations resulting with that. But I got to tell you, the thing that bothers me most is when I work a shift, and my only set shift is every other weekend, 3 to 11. Is taking these calls from these young pediatric patients as young as 6 years old who are trying to harm themselves. And as previously stated by the previous speaker, we don't know what their understanding of that is, but they know that they're being hurt in some manner that they don't want to be around anymore, and they want it to stop, and they'll take something. We get consistently 10, 11, 12-year-olds. And then 16-year-olds are bread and butter, and it's just one after another. This is a poison center's bread and butter, is managing overdoses and primarily in teens and tweens, and it's very, very sad. So I won't belabor this point other than I'm glad to see that this very important work is being done by people a lot smarter than me, these collaborative efforts, and so it really gives me a little bit of hope, sometimes seeing it through my lens. So thank you all for doing that, and to the previous speaker and everybody who's affiliated with those efforts. And that got worse through COVID. There again, we already know about that. I just wanted to bring up, since this is fall, carbon monoxide is the leading poisoning killer of everybody in the United States. And so it's odorless, colorless, and tasteless. So make sure, I know in Minnesota, it's state law to have a CO detector within 10 feet of every sleeping area. That law doesn't have any teeth to it, so to speak. There's no legal retribution that can be brought upon you for not doing it. It's more just going ahead and legislating to educate kind of thing. But carbon monoxide detectors are essential. So this is what you'll see. You'll see mild drowsiness, you'll see nausea and vomiting, and you'll get a headache, specifically one that feels like your head is being squeezed too tight, and that's kind of a dead giveaway. If everybody in the home has flu-like symptoms, you've just turned on your furnace. That's the #1 appliance that we see causing carbon monoxide poisoning in the home. Please do that. Anybody who's affiliated with EMS. This is something, I was also the EMS training officer for Lexington Fire for 5 years. And one of the things that I had them do through their local Lions Club was to go ahead and have them purchase these CO detectors. They put them on their first in bags, and they kind of lock right in there so that you can't pull them off. You literally have to cut them off. They're less than $200. They're good for 2 years. And what happens is we actually had an incident in northern Minnesota where we had some first responders respond to a full arrest. This gentleman was a full code. They were working on him in a rural area. So sheriff's deputies were some of the first to respond. The local volunteer ambulance service came. They were working on this gentleman, and they wound up being overcome by carbon monoxide poisoning, and 3 had to be flown down and put in the hyperbaric chamber, which is out of Hennepin County Medical Center in Minneapolis. And so all they needed was this. And so I do advocate, if you have any extra money or funds for your first responders or anybody who's going to homes regularly, to have one of these strapped to their first aid medical bag. So let's talk about drugs of abuse in the time that we have left. This is the biggest thing that we're seeing now. Having been on the street and still having close ties to things that are on the street, and working at the Poison Center, is nothing is what it appears to be anymore. So the Xanax down here in the lower left, these are what we call 2 milligrams Xanibar or Xanax Dividabars. They're called Xanibars on the streets. They're probably one of the most sought after prescription drugs sold illicitly or illegally on the streets is the 2 milligram Xanibars. The one on the left is actually fake. The one on the right is the real one. Now it's easy to see side by side that one is fake. But if you didn't have the luxury of seeing the one on the right, you'd probably look and see the one on the left is like, well, that looks pretty legit. And so I have 4 kids. My 2 youngest are 20 and 23. And I tell them all the time, you know, if you're going to dabble in drugs, even marijuana nowadays is adulterated with stuff. You don't know what's in this stuff. And nothing is what it seems. The K9, the blue pills in the lower right, were actually seized in a small town in southeastern Minnesota in Northfield, and these were seized by law enforcement and tested, and they were found to have cocaine in them. They were supposed to be 30 milligram oxycodone is what a K9 is, if you look it up by its pill imprint, but it also had fentanyl, carfentanil, and cocaine in them. So nothing is what it seems on the streets, and that includes every type of medication you can imagine. They talk about dropping acid, you know, like they did back in the 60s and 70s. There's no real lysergic acid out there. There's a finite amount of that out there, and most of what they're calling LSD is actually basalt to what they call hallucinogenic amphetamine or phenethylamine, like MDMA or MAMA. So there's a lot of reuse of words that are not accurate as to what they actually do. So this is part of my expert witnessing with the Hennepin Prosecutor's Office. There is a gentleman who was caught with 7.44 pounds of pure fentanyl. They wanted me to come up with a strategy to figure out how to go ahead and convince a jury of his peers that this was a bad thing. And so what I came up with was I converted 7.44 pounds, which is like a fat chihuahua. And my first question was, why didn't the feds take this? This got bumped down to the county level. And the reasoning is because the feds don't take it because this gentleman wanted to plead and they didn't want to take a chance of having a loss on their record. So it got bumped down to the county level is what I was told. And so anyway, I calculated that 7.44 pounds of pure fentanyl was equivalent to 3.3 million milligrams of fentanyl. So if you have major back surgery, some type of major orthopedic surgery, you need post-operative pain, standard of care is to give 0.12 milligrams of fentanyl, usually IV. That would be the equivalent of 28 million doses out of the 7.44 pounds. Same thing if you're going in for a colonoscopy or endoscopy, it's 11 plus million doses. And then the widely accepted lethal dose in the peer-reviewed literature in opiate naive people that are not on opiates therapeutically, is almost 1.4 million. And so my point was that amount of fentanyl, if properly distributed, could kill every man, woman, and child in Minneapolis and St. Paul proper and a couple outside in the first-ring suburbs. Needless to say, he decided to plead out under the advice of his defense attorney. But this isn't everything now. People say, I use heroin, I use this. It's all mostly fentanyl now, by and large, or fentanyl analogs. These are fentanyl analogs that are structurally similar, but have different kinetics that we don't understand because they've never gone through the FDA approval process. So we can see even more potent fentanyl out there if they're in slightly different forms. This was just came out very recently that fentanyl, that we're losing more children to fentanyl, and most of those are obviously teenagers who are experimenting with drug use. because of this adulteration that they don't understand. We're not even getting marijuana now that's been adulterated with fentanyl now, and seeing some serious morbidity and mortality as a result of that. Thankfully, it hasn't been a lot, but the potential is there. So just imagine your kid or professionals. I can't believe how many professionals that I know that smoke weed, but they do. But if you got them from a different dealer and all of a sudden they decided to put some fentanyl in there and you didn't have any naloxone around, you would potentially die. So it's become very, very serious. Fentanyl exposures in toddlers have increased. There again, whenever you have more supply of things in a home, more people using it, there are going to be more children exposed to this, unfortunately. So as you can see here, this was some Minnesota data that we were asked about specifically to come up with from some local news stations. And we had 66 exposures to children under the age of 3 years old since 2002 regarding fentanyl. And so the other thing about this is if you're out there and you have children come into your ER, your general urine drug screen is not going to be very accurate. You can, a good defense attorney can put holes into urinary drug screens because they're simply immunoassays, which means they're not super accurate. They can have lots of false positives, false negatives, all those sorts of things. And so the standard of care is in children that might have been impacted by one of these drugs, either intentionally or unintentionally, is to go ahead and get a comprehensive drug screen. And very few healthcare facilities have the ability to get a comprehensive drug screen in real time. So it may not be of clinical use, but it might be of use further down the line when it comes to children protective services and those things. And I'm not an expert in those areas. I do the medical stuff, and unfortunately those entities have to exist. But remember, you need a comprehensive drug screen, and that's probably going to be a send out. So you might want to get that rolling early. So here's the other thing. Now, it's bad enough that we've got fentanyl. Now we're having our fentanyl contaminated with xylazine. And we happen to be one of 2 states now where we're seeing more xylazine contamination. So if you remember, fentanyl used to be sometimes adulterated with carfentanil, which we know is a veterinary drug, which even is exponentially more potent than even regular fentanyl is. And people were dying because of just little tiny amounts of it that were being put into regular fentanyl. That fad has kind of faded away. We don't see it very often, the carfentanil is being used. But here's another veterinary drug that's being used to put big animals down that's a non-opiate. And it's being put into these, into the fentanyl. So this is also prompting a lot of people to go ahead and start saying, hey, we now have Narcan-resistant opioids. That could not be further from the truth. The problem is we're not getting resistant drugs, opioids to Narcan. What we're getting is we're having these adulterated drugs. So for example, let's say you get fentanyl, half of it's contaminated or adulterated xylazine. The xylazine is going to be much longer acting. It's going to cause bradycardia, hypotension. They're going to have significant clinical effects probably for the better part of 12 to 24 hours. There again, this is not a drug that is approved for use in humans, so its kinetics are not well known. It is all known that it does cause peripheral ischemia or these nasty looking wounds here. This is not opportunistic bacteria from IV drug users. This is actually as an adverse effect from xylazine use in humans that this happens. As many things in toxicology, the pathophysiology is poorly known. This is not from 1 or 2 uses. This is a chronic user of somebody with fentanyl that's been contaminated with xylazine. But imagine now you go to somebody who's down, they've got pinpoint pupils, you give them 4 milligrams of intranasal naloxone, they don't respond. Their friends say, hey, we just did fentanyl, you give them more, and maybe it works a little bit, but not like it should. And maybe they get a little bit, maybe they start breathing a little bit, but it's still not enough to go ahead and sustain life. And so you have to supplement then with adjunct airways, et cetera, et cetera. So this is known as dope or trank on the street. But the biggest thing I want to get out there is it's a total misnomer that these opioids are now getting Narcan resistant. They are simply not. They're just being adulterated with things that does not respond to Narcan. Overdose response strategy. 2021. Thankfully, this hasn't been huge. We haven't seen a lot of this, but it is out there. So let's talk about opiate substitutes. Order, and you don't get your medicine, your opiates, what you like. you're going to start not life-threatening, but if you talk to somebody, it is absolutely horrible. They would, I love talking to the patients and asking them about these things. And they say, dude, I'd rather die than go ahead and go through withdrawal. And so that's the number one reason that people don't get off opioids, because it is so hard. The withdrawal is so terrible to get through. And so these are some of the things that they use that they can't get their opioids right away. The antidiarrheal. This used to be a Schedule 5, interestingly enough, if you look back at pharmaceutical history. And it was because it's known as poor man's methadone. You can see the loperamide, half of the chemical structure there. And I'm no expert. I'm a 2-year community college nurse that had basic chemistry. So, but I can recognize that looks structurally much the same and could potentially cause methadone-like effects. And so this is a way that's advertised that if you happen to be hooked on opioids, it's ruining your life, it's ruining your family, you don't want to go through the stigma of going to Hazelton or some other organized type of treatment for this, you want to do it on your own, and you Google it, it'll tell you to take 5 to 7 boxes of this. 5 to 7 boxes. Now, there again, most people think, well, it's over the counter, they wouldn't sell it, even if you take too much of it, and it's not going to cause any harm. Here's the problem we're seeing with people that are using this as a opioid replacement. Oh, I didn't put it in there. So what we're seeing is we're seeing torsades, and basically at the EKG, instead of looking like the blip, it looks like this. It's lines, and you will not sustain torsades very long without treatment. And so this will actually, as an undeclared adverse clinical effect in large amounts, will cause torsades. So anyway, and just an FYI on the side, since this is a pediatric conference, if kids get into this is probably one of the most dangerous things that can be in your home, is if kids get into this, because 1 or 2 of these have been well documented in the peer-reviewed ER literature and pediatric literature to cause insufficient respirations or no respirations, because it does activate some of the opioid receptors. Narcan in larger amounts will reverse this. So just FYI. Let's talk about weed. So my experience with weed, and some of you obviously don't know the area, but I graduated from a northwestern suburban high school in Minnesota, from Minneapolis, Osseo Senior High in 1983. Now, if it was outside of wrestling season and I wanted to go get stoned, and I walked up to the edge of the property and asked and gave $5 to the guy that had long stringy black hair listening to Ozzy Osbourne when he's the lead singer for Black Sabbath on his Sony Walkman, and he gave me a bag full of weed, $5 worth of weed, and not parsley, and it was the good stuff. That would have been Thai Sticker, Colombian Gold back in my day. It was 2.5 to 5%. The good stuff was 2.5 to 5% THC content. So my daughter pointed out to me that, Dad, that's ditchweed. I understand that, but I'm an old guy, and the worst that ever happened to us was we sat and laughed too hard at Scooby-Doo and ate too many Totino's party pizzas. Not to make light of it, but that's, in all reality, that's what our experience is. We all know this is a level or a Schedule 1 substance, so it has not been prospectively double-blinded studied because it's really safe, right? Well, we're finding out that that isn't always necessarily the case. I just spoke at the Minnesota Chiefs conference in their EMS tract, and I had a room full of about probably almost 50 people, and I asked the question, how many guys have transported somebody, or I've seen somebody in your EMS career recently that is paranoid and agitated now from marijuana? And there was at least probably 25 and maybe more % of the room raised their hands. Now, they're not agitated to the point where I'm worried about my safety, scene safe BSI kind of stuff. But it's not the typical, we just thought more that they'd sit on the couch more, not go anywhere, and just eat more munchies, is not the case. We're finding out that paranoia is happening. There's cyclic vomiting syndrome, which is happening, which can be life-threatening, and all kinds of stuff. So what's been legalized, I think we are the 23rd state in the United States to go ahead and legalize edibles on site within the state. I think they were a little short-sighted in that. And now we can sell them, but there's still nothing in place until 2025 in our state to actually batch test to make sure there's not more than 5 milligrams per edible of Delta 9 or THC, and not more than 10 pieces within per packet. And that's what the guidelines are supposed to be. And we've already had the Minnesota State Board of Pharmacy here sue 3 different manufacturers because they had up to 10 times more of that within their edibles and were sending people to the hospital. So we have Delta 8, which technically, if you see, it's called lightweight. It's the same chemical structure, very, very slight deviant of it. Supposedly, if you don't like marijuana because it's too psychoactive for you, the Delta 8 will provide less psychoactivity for you. We have HHC, we have THCO, THCP, all these different analogs. And as you can see here, the chemical structures are very similar. So some may produce a better high with less dry mouth, et cetera, et cetera. But the only one that's legal here in Minnesota is the Delta 9. Technically, Delta 8 is not legal, and it's not legal by the federal 2008 federal farm bill, which delineates the legality of marijuana at the federal level. So here's what there's been studies done on this actually by the French, and retrospectively. We're finding out now that children are not, and we all know this, children are not little adults. I've not run into an adult that has had serious morbidity and mortality from utilizing marijuana or THC products. That's what they are, not adulterated with something more serious, okay? Do they get paranoid? Yes. So they get paranoia that doesn't result in any serious clinical effects. They do get tachycardic, it's because they have that fear response. And so we give them, a milligram of benzos and send them on their way. But they're clogging up a lot of our ERs because we didn't teach people about the differences between smoking and eating. And it just blows me away that we have one of the better departments of health, in my personal opinion, in the United States through the Minnesota Department of Health, that the people who crafted these bills did not go ahead and put in basic education that if you eat these, it's going to take 30 to 90 minutes to kick in, and wait before you take more, because more is not better. More will send you to the ER because you will have a feeling of impending doom. For children, we are finding children. Now, this is my experience working at the Minnesota Poison Control System, is we've had a handful of children that needed intubation for insufficient respiratory drive, secondary to marijuana only. And we've run labs on them to find out that presumptively that there was nothing else in their system except THC. We had a case where one child was transferred from another neighboring state to our state that supposedly had an asystole episode 12 hours after ingesting marijuana-infused gummies. Now, there again, we can't totally pin it on that, but we are starting to see more things where children are being affected. We have seen seizures from this, from marijuana only in young children, just regular Delta 9. And so obviously the form that it's in, we need to be very, very proactive in people that use these. And I'll be the first to admit, now that I'm not in the fire service anymore, I use a Delta 8 gummy, a half of one, about once every 2 weeks, because my body's so broken. I need both shoulders replaced. I'm an absolute physical mess. And so I do take one just to be able to sleep through the night, and it does help me. But I'm using it responsibly, and so I think there is a place for this. So I'm not bashing the use of THC, but we really we're testing out the general public and our children with something based on our experience with it back in 1983, so to speak. So we can see serious morbidity and mortality in children from regular THC when excessive gummies and edibles are eaten. So when you smoke it, obviously, you all had the guy you probably grew up with that, smoked a lot of weed, and they took a giant hit of the good stuff. And he's like, dude, man, the projector is like, they're watching me. It's like, dude, put the bong down, have a bag of Funyuns, you're going to be fine, kind of thing, right? So you can kind of titrate your high when you smoke it because it crosses your blood-brain barrier. Now, when you ingest it, one of the things that a lot of people are not aware of, and what I'm challenging all of you to let your friend circles and everybody know that more is not better with edibles, because it changes into 11-hydroxyl THC, which is a more psychoactive form and much longer acting form than THC is. This is out of clinical pharmacokinetics, and there again, this is more kind of supposition. Just remember, it's going to take probably a couple hours to kick in. So we're a very patient society, right? Not. And so when your buddy tries some, just say, hey, let's try the lowest dose possible, maybe half that. Let's wait 2 hours and see what happens. And then maybe next time you can take double that kind of thing. So here's kind of what we know happens with THC. You get the munchies, you get your heart racing, your eyes get bloodshot, maybe some anxiety, hopefully, depending on the amount. I thought this was interesting. is that, and this is from 1998 to 2023, is 3 times more potent than 25 years ago. Well, your THC content in honey oil or shatter or beeswax now, which is these are all smokable forms of marijuana, THC, is up to 90%. You can grow plants that have up to 60% THC content. And so this is higher than we've ever seen before and what our personal experience is with. And we're starting to see different things happening. This is my slide for Delta 8 and Delta 9. I kind of compare it to, instead of eating that double cheeseburger that's going to make you feel like crap later, you get smart like I am as I get older, and you get the single cheeseburger and you enjoy it a lot more. That's what that's kind of my Delta 8 to Delta 9 comparison. Delta 10, this is a quote. There's little research about this other than what people experience is. So talk to people who use these things, especially in EMS, talk to what does it make you feel like kind of stuff. CBD, this is a form that should not get you high. It should be it's not psychoactive. It shouldn't get you high. It's not going to pop positive in your analysis tests. If it's true CBD, the problem is that when you online, it's hard to go ahead and vet that. I've had people question, say, hey, can I use CBD in my kid? I've got a family member who has a kid who has severe ADHD and tries to take summer vacations from that and supplement that with CBD. And they ask me, obviously being supposedly the expert in this, and I'm like, well, there's no data. I can't tell you for sure. My experience is that generally CBD, if that's indeed what it is generally not a big deal. Some preliminary investigation has shown some correlation with reducing anxiety, with reducing use as an anti-inflammatory, maybe an anti-epileptic type of medication. Now, I can tell you, I tried this first. I tried the Charlotte's Web, and there again, I have no financial interest or stocks in any of this stuff. But I went to Charlotte's Web and utilized that CBD before I tried the Delta 8 after I got out of the fire service, because my buddy was a pharmacist who worked for the state of Pennsylvania in their marijuana clinics. And so he said, number one, this would not pop positive, which would get me out of the fire service, and I didn't want to be impaired. And so he said, try this. What they do is they vet it through a third party, an independent, well-known laboratory, but you pay a lot for it. I paid $119 for month's supply, and I could not feel any perceivable difference, so I abandoned it. So as far as children using this, I don't have the answer to that. Compared to the other types of cannabinoids that are out there, this is probably safer, but we don't know that. So that's kind of an interesting thing. I think it can be beneficial, but I think we've really dropped the ball on making sure that what was advertised is being done, especially in our state and probably in the other states. And there's 22 states that went before us. So I don't understand that. And why we're not doing more to educate people about the differences between smoking it and eating it and the delay of effects that it can cause, so that we can free up these emergency rooms from people that are just feeling like they're going to die, but really aren't from a clinical perspective. Just kind of want to quick on holiday plants. Poinsettias, contrary to popular belief, are not significantly toxic plants to people. If you eat enough of them, they'll cause GI effects, but they're safe plants to have in your home with children. I can't speak to animals. Our poison center doesn't take animal calls, but they are safe for children. So this is one of the myths we try and bust every year. Now there's some other ones. None of these are significantly poisonous to children. Some of them cause GI effects, like the mistletoe and the holly, in larger amounts, but there again, you generally don't need enough to cause anything more than GI effects. So with that, make sure you call the poison center. Keep all potential poisons up high and out of sight, or preferably down low and locked up. And remember, young kids are pleasure seekers. So don't leave your edibles out that look like regular gummy bears, or they will all be eaten and your kid might be intubated at a hospital, unfortunately. So with that, I'd like to thank all the EMSCs nationwide for which I've been blessed to be a part of our EMSC does with Chelsea and the wonderful job that she does, as all the other chapters do. So with that, we do have some through our poison center. And peace and love be unto you. We need more contact information if you need it. Other than that, I'd be happy to field any questions you have. And thank you very much for attending this. And the first two talks were just excellent. So Right. Exactly what we needed. First, just terrible world, but we can do some good. So let's keep at it. And that's all I have.
Thank you so much, Kirk. We do have some questions. One, can you repeat, what did you say is the treatment if children take Imodium?
Naloxone. If they're having insufficient respiratory drive, because it does act on some opioid receptors, and the purported mechanism of action in children is that there's 5 major classes of opioid receptors, and there's a bunch of minor ones. It used to be 3, now we're up to 5. And there's a bunch of smaller ones, but we think that there's some cross-reactivity and cross-sensitivity between like mu and kappa receptors, other opioid receptors, and think that that's the reason that they're causing respiratory insufficiency in very young children. And to qualify that, when I say very young, and I'm just saying this from my experience of having taken a lot of cases, they're generally less than 3. And the younger they are taking the 1 or 2 Imodium, the more likely they are to have respiratory insufficiency or arrest. So it's just using Narcan.
Perfect. And then someone was clarifying how long the carbon monoxide clip-ons last.
You know, it can be a year to 2 years. It all depends on which ones you buy. Obviously, the more expensive or the more money you spend, the longer it can potentially be good, but you have to follow whatever the manufacturer says. I do know for a couple $100, you can get one that's good for at least 1 year, and a lot of them are a couple of years before their electronics wear out and they're not reliable. But they are very affordable, and I would challenge anybody to go ahead and if you're an EMS, to have one of these on your first in bag, or even on your personal bags. I have one for my own personal medical bag that I keep in my truck too. So
Okay, and do you recommend that everyone have a naloxone kit? Can it be left in a vehicle or carried in a bag?
great question. I think you have to go state by state on that. I know in our state, we have allowed the general citizens to use naloxone, and a pharmacist in our state can actually write a prescription at the pharmacies to go ahead and sell you a naloxone, intranasal 4 milligram naloxone kit. My personal opinion is I think everybody should have one. I know if you go to a Hennepin healthcare pharmacy as an employee, I can get one for $15. There are some programs, and I don't know if this is nationwide, so forgive me for not knowing that, but within our state that you can take a like an opiate prevention class, and they will provide you a free naloxone kit. So I think everybody should have one, because you just never know. I mean, even if your kid was just smoking weed, or your partner was for some reason, and all of a sudden it had fentanyl in it, you didn't know it, and they're down, we can go ahead and save that person's life. So I would highly encourage everybody that possibly can to give it. You're not going to hurt anybody by giving it. In a small percentage of the time, you might induce withdrawal, and they might say some interesting things about your mom that you've never thought possible, but they generally are, in my experience, have not been, get physical with you. So yes, and you can carry it anywhere you want. I keep one in my glove compartment. I keep one in my medical kit in my truck. So yes, I would say everybody that can should get one.
Awesome. There was a follow-up question, would a Narcan kit in a hot car be affected? And there was a comment saying, do not let naloxone freeze and don't store it in the vehicle in the wintertime.
Right. Yeah. Sorry about that. There hasn't been really good testing. We've looked for this. I know in our state, all the state troopers, Minnesota state troopers, had a special climate controlled storage area put into their squads to keep the Narcan in. My understanding is that this is anecdotally, that it's been frozen. This is anecdotally from people that I trust that are in EMS at high levels, that it's frozen, it's thawed out, and they had no other option other than to intubate somebody, and they used it and it worked. So we don't know that. I would just say follow the manufacturer's guidance on that. Try and prevent it from getting too hot or getting too cold, but we don't really know what its efficacy is. And if anybody has better information, I would welcome that.
Perfect. And I've got time for about 2 more questions, and anything else we can send you to be answered in the post-symposium information. One question is, would you give naloxone if it is expired?
As a healthcare professional, based on my licensure, no, I can't give expired medications. Would I, in my personal practice, if it were a family member? Absolutely. I don't know that we have any good information that it's going to turn into anything that's toxic. So my own personal perspective is yes. From a Minnesota poison control system standpoint, I would say we don't give expired medication. So.
Excellent, thank you. And one final question. And this is actually from Corolla, so she may need to step in and correct me here. I believe it was in reference to the suicide attempt phone calls from the teenagers, and she asked who is making the calls.
Usually it's a friend, or it is the other the healthcare facility, and that's because they've told somebody, and then they rushed them right in before calling anybody. So I would say mostly ER providers, and then the other one is friends of the people who have done this. So
what we're finding out when we go out to the school systems and stuff is the children or the kids are testing, I guess, if you will, or they're playing with their drugs. They're doing it in school versus at home because they know at school that they're going to get help a little bit quicker. Kind of an interesting thought process.
Okay, awesome. And I'm going to turn it back over to Brittany.